Several authors have demonstrated the correlation between mean pulmonary artery pressure and the pulmonary acceleration time, which is obtained by placing the pulsed wave sample volume either in the proximal pulmonary artery or in the right ventricular outflow tract just proximal to the valve. We favor this latter position. The resultant RVOT velocity envelope is used to determine the acceleration time, which is measured from the onset of flow to the peak. In pulmonary hypertension, the acceleration time becomes shortened. In a largely non-simultaneous study, Dr. Dabastani and colleagues compared catheter-measured mean pulmonary artery pressure and the PA acceleration time. Acceleration times greater than 120 milliseconds correlate with normal pulmonary artery pressure. When we focus on those patients with acceleration times less than 120, there is a linear relationship between the mean PA pressure and the acceleration time. The R value is minus 0.87, and the standard error of the estimate is 8.3 millimeters of mercury. The regression equation from Dabastani's study is the mean pulmonary artery pressure is equal to 90 minus 0.62 times the pulmonary acceleration time. This 48-year-old female has severe mitral stenosis. We will use her pulmonary acceleration time to assess the degree of pulmonary hypertension. A pulse sample volume is positioned in the right ventricular outflow tract with the cursor approximately parallel to the expected flow direction. The velocity spectrum has a very early peak, and there is also notching of the deceleration slope. Both of these features are typical for significant pulmonary hypertension. The pulmonary acceleration time is measured by placing one cursor at the onset of flow and one at peak flow. In this case, the acceleration time is 55 milliseconds. Utilizing the previously mentioned regression equation, her mean pulmonary artery pressure is 90 minus 0.62 times 55 milliseconds, which is 55 millimeters of mercury. She therefore has severe pulmonary hypertension secondary to mitral stenosis. As a rule, pulmonary acceleration times of 75 milliseconds or less correlate with severe pulmonary hypertension. Pulmonary regurgitation can be used to approximate the pulmonary artery diastolic pressure. This pulmonary regurgitation color jet is from a 52-year-old patient with severe pulmonary hypertension. The marked degree of color mixing is due to the high velocity of the regurgitant jet. He also has mild aortic regurgitation. The velocity of pulmonary regurgitation is determined by the diastolic pressure gradient between the pulmonary artery and right ventricle. The pulmonary regurgitant velocity spectrum can be obtained by CW Doppler. The diastolic pulmonary artery to right ventricular pressure gradient is equal to 4 times the square of the PR velocity. Rearranging the equation, the pulmonary artery diastolic pressure is obtained by adding the RV diastolic pressure to 4 times the PR velocity squared. Since the right atrium communicates with the right ventricle in diastole, we can substitute RA pressure for the RV pressure term in the equation. And we can use a clinical estimate of the RA pressure in combination with Doppler measurement of PR velocity to calculate the pulmonary artery diastolic pressure. Masuyama and colleagues evaluated this Doppler method for calculating pulmonary artery diastolic pressure in 45 patients, comparing the Doppler-derived PA diastolic pressure to PA diastolic pressure obtained by right heart catheterization. This figure illustrates their results, with catheter-measured PA end diastolic pressure on the x-axis. The Doppler-measured PA end diastolic pressure is plotted on the y-axis, using angle correction in determining the velocity of pulmonary regurgitation at end diastole. For this figure, the term in the Doppler calculation for right atrial pressure was taken from catheter measurement rather than clinical estimate. They obtained an excellent R value of 0.96 with a standard error of the estimate of 4 millimeters of mercury. This patient's pulmonary hypertension was felt to be thromboembolic in etiology. This is the CW spectrum of his pulmonary regurgitation. As is typical for patients with pulmonary hypertension, both the early and end diastolic velocities are increased. His early diastolic velocity measures 2.7 meters per second. The end diastolic velocity is 1.6 meters per second. From the Bernoulli equation, the end diastolic pressure gradient is 10 millimeters of mercury. We add to this his jugular venous pressure of 12, determined at the bedside, and arrive at a pulmonary artery end diastolic pressure of 22 millimeters of mercury. Having detailed the versatility of Doppler for characterizing right ventricular and pulmonary artery pressures, we will now discuss the 2D echo assessment of the secondary features of pulmonary hypertension. Changes in cardiovascular morphology and function secondary to pulmonary hypertension include enlargement of the pulmonary artery, mid-systolic notching of the pulmonary valve motion, right ventricular hypertrophy, and right ventricular enlargement, variable reduction in right ventricular systolic function, a D shape to the left ventricle, and signs of right atrial pressure overload, such as enlargement of the coronary sinus. We have previously alluded to mid-systolic notching of the RVOT, or pulmonary artery Doppler velocity spectrum, as a sign of significant pulmonary hypertension. This flow velocity pattern is associated with mid-systolic notching of pulmonary valve motion. This 48-year-old male was referred with end-stage aortic stenosis, which had resulted in severe reduction in LV function and severe pulmonary hypertension. This is the densely calcified aortic valve, and this is the left atrial appendage. Attention is being directed to the pulmonary valve. In real time, pay attention to the quick, bouncing motion of the valve cusp in systole. This mid-systolic closure of the pulmonary valve creates a W shape for pulmonary valve motion when recorded on M mode. Pulmonary hypertension causes pressure overload of the right ventricle. This specimen, provided by Dr. William Edwards, is from a patient who expired secondary to thromboembolic pulmonary hypertension. The right ventricle is hypertrophied, both the free wall and the trabeculae. The right ventricle is also severely enlarged. Pressure overload of the right ventricle also leads to flattening of the ventricular septum, which gives the left ventricle this characteristic D-shaped appearance. This young female with severe primary pulmonary hypertension has developed severe enlargement of the right ventricle with hypertrophy of the trabeculae. Pressure overload on the right side has flattened the ventricular septum, giving the left ventricle a D shape. This patient developed severe pulmonary hypertension because of an uncorrected patent ductus arteriosus. The right ventricular hypertrophy is striking. This patient has mitral stenosis, and she also has tricuspid stenosis and regurgitation, all of which lead to right atrial hypertension. The elevated right atrial pressure has led to enlargement of the coronary sinus, which is here in the left AV groove. Compare its size to the descending aorta, which is here. We will now discuss the echocardiographic diagnosis of pulmonary valve lesions, beginning with a brief review of pulmonary stenosis. This lesion was discussed in detail on tape number 6 in this series. Pulmonary stenosis is an uncommon entity, which is most often congenital in etiology. This 22-year-old female has mild pulmonary stenosis. This is the right ventricular outflow tract. As expected, the pulmonary artery is enlarged. The pulmonary valve opens with a doming motion, which is characteristic for valvular pulmonary stenosis. This patient also has mild congenital valvular pulmonary stenosis. The transducer is in an upper left parasternal position. A thickened pulmonic cusp is evident. As is often the case, it is difficult to completely visualize systolic opening of the valve. Color flow imaging demonstrates acceleration of blood flow across the stenotic valve with color aliasing. Color flow also identifies moderate pulmonary regurgitation. Because of frequent difficulty in visualizing the pulmonary valve in systole, Doppler and color flow imaging are particularly valuable for the assessment of pulmonary stenosis. Here the same patient is being examined with a non-imaging probe placed at the upper left sternal border and angled laterally and superiorly. The maximum systolic velocity across the valve is 2.2 meters per second, which calculated to a maximum gradient of 19 millimeters of mercury. The mean gradient is 11 millimeters of mercury. Thus, Doppler verifies that this is mild pulmonary stenosis. Doppler gradient determination for right ventricular outflow tract obstruction, including valvular pulmonary stenosis, was validated in this study from our institution, published in 1986. 38 patients with right ventricular outflow tract obstruction were studied by simultaneous continuous wave Doppler and cardiac catheterization. This graph compares the maximum instantaneous RVOT gradient obtained by Doppler with the maximum catheter gradient. Note the excellent correlation with an R value of 0.96 and a standard error of the estimate of 9 millimeters of mercury. As with tricuspid regurgitation, pulmonary regurgitation can be identified in the majority of normal individuals. This study is from a healthy 15-year-old male. Mild pulmonary regurgitation has a characteristic candle flame appearance in the right ventricular outflow tract. Frequently, part of the regurgitant jet originates near the base of the valve cusp. If the pulmonary valve appears normal on 2D exam, and the color extent of the PR is in the trivial to mild range, we consider the regurgitation to be physiologic. This patient has cardiac amyloidosis. The mild increased thickness of the aortic and pulmonary valves is due to amyloid deposition. The spatial extent of the regurgitant color signals is slightly greater than that of the previous case. This is a color M mode from the same patient. The M mode cursor has been directed across the pulmonary valve. The blue signals represent ejection through the opened valve. This red holodiastolic signal adjacent to the M mode of the closed valve represents pulmonary regurgitation. Since aortic and pulmonary regurgitation are sometimes detected from the same transducer position, it is important to identify clues that differentiate the velocity spectra. This 88-year-old female had moderate aortic stenosis with associated regurgitation. Both aortic and pulmonary regurgitation were detected using an apical position for the non-imaging probe. Because the diastolic gradient between aorta and left ventricle is larger than the diastolic gradient between pulmonary artery and right ventricle, the early diastolic velocity of aortic regurgitation will be higher than the corresponding velocity of pulmonary regurgitation. For fully defined aortic regurgitation spectra, as we see here, the early diastolic velocity usually is 4 meters per second or higher. In addition, because of the higher level of aortic diastolic pressure, atrial systole does not alter the AR spectrum, except when the LVN diastolic pressure is markedly elevated. There is no atrial notch on this AR spectrum. This is the pulmonary regurgitation spectrum from the same patient. You will notice that the early diastolic velocity is only 1.7 meters per second, and the end diastolic velocity is only 1.2 meters per second, much lower than the corresponding AR velocities. In addition, since PA diastolic pressure is relatively close to RV diastolic pressure, the effect of atrial systole is often evident on the PR velocity spectrum. Observe the late diastolic notching, which follows the P wave on the ECG. We will conclude this section on diseases of the tricuspid and pulmonary valves with a discussion of a disease which typically affects both of these valves. Carcinoid tumors secrete serotonin and other vasoactive substances. The carcinoid syndrome most often occurs in the setting of a malignant carcinoid tumor in the small bowel with hepatic metastases. The liver metastases secrete serotonin and other mediators, unmetabolized, directly into the right heart, and these secretory products can cause flushing, diarrhea, wheezing, and cardiac lesions. Since serotonin is metabolized in the pulmonary circulation, carcinoid heart disease is typically limited to the right heart with fibrosis of the endothelium. This is an example of thickened and retracted tricuspid leaflets secondary to carcinoid. In this case, the endothelium on the left side and the mitral valve also appear involved. When this happens, one must exclude a right-to-left shunt. However, left heart involvement is also seen with active pulmonary metastases or when the primary tumor is a bronchial carcinoid. As with the tricuspid valve, carcinoid involvement of the pulmonary valve results in retracted, rigid cusps. This 72-year-old female had an ileal carcinoid tumor metastatic to the liver. Her tricuspid valve has an appearance that is classic for carcinoid involvement. The leaflets are thickened, short, and retracted. In real time, you will see that the valve is fixed in a semi-open position. This patient also has carcinoid heart disease. On this parasternal RV inflow view, the right atrium and right ventricle are enlarged. The tricuspid leaflets are thickened and fixed in a semi-open position. This is an apex down 4-chamber view which demonstrates severe tricuspid regurgitation. In diastole, there is high-velocity, turbulent flow through the stenotic tricuspid valve. A duplex transducer is used to guide a CW cursor across the tricuspid valve. The early diastolic velocity is increased to 1.8 meters per second, and the deceleration slope is reduced due to the tricuspid stenosis. The tricuspid regurgitation velocity is only 1.9 meters per second. This equates with an RV systolic pressure of 34 millimeters of mercury. 20 millimeters of mercury is added because of severe tricuspid regurgitation. Now the pulsed wave mode is operational with the sample volume on the right atrial side of the tricuspid leaflets. This laminar signal is typical for wide open tricuspid regurgitation. This is a left upper parasternal view from the same patient. With carcinoid involvement, the pulmonary cusps are typically quite difficult to image because they are short, retracted, and immobile. The mosaic systolic jet is consistent with pulmonary stenosis. In diastole, the color map from pulmonary regurgitation fills the enlarged RVOT. Using a continuous wave transducer, we note a systolic velocity peak at 2 meters per second. Pulmonary stenosis is mild, with a maximum gradient of 16 millimeters of mercury. The severe pulmonary regurgitation has a very steep deceleration slope. Furthermore, after atrial systole, there is diastolic forward flow in the pulmonary artery. This results from severe elevation of the right ventricular end diastolic pressure with premature opening of the pulmonary valve. Converting to pulsed wave mode, the sample volume is placed in the pulmonary valve orifice. The diastolic forward flow is clearly identified. In real time, you can hear this late diastolic component of forward flow. Having discussed the use of 2D echo in delineating morphologic and functional disturbances associated with pulmonary and tricuspid valve disease, and the use of Doppler to define right heart hemodynamics, we will conclude this portion of the video program. We will proceed next with a discussion of echocardiographic assessment of diseases of the aorta.